Hi there, this is Dr. Tawfiq Al-Mzaini. We are focusing on teaching clinical emergency medicine. Mastery of emergency medicine is really the paradigm focusing on 6 aspects of management of sick patients in emergency department. Started with clinical assessments of the patient, data analysis, evidence-based, managerial skills, procedures, and emergency radiology. Managing patients in emergency department is really a cocktail or a mixture of multiple items of these things. Today, we will present emergency radiology cases that we face in the emergency department. We'll start with the first 5 lessons, starting from number 10. When we have a patient presented to the emergency department with chest pain, usually we take history, do physical examinations, and we proceed for ECG, laboratory investigations, and we order chest X-ray. Indeed, chest X-ray is not indicated in young, healthy patients. In one study done by Rothrock 10 years ago, he came up with multiple risk factors, at which it will help the emergency department to push him or encourage them for doing a chest X-ray. These factors were not really taken much by emergency physicians until 2018, when one emergency physician in Newsom and his colleagues in Canada, they have reviewed this aspect again, and they came up with 10 red flags factors pushing or encouraging the emergency physicians to consider doing chest X-ray if patient presented with chest pain. Indeed, the patient needs to have one criteria of this in order to have a finding of the chest X-ray. Newsom and his colleague reviewed 1,100 patients and only found that 70 of patients, they have abnormal finding. For example, congestive heart failure or pneumonia or pleural effusion or a mass. So if you ignore these criteria, the chance you will have abnormal findings in the chest X-ray is only 6.4%, and 94% of the time the X-ray will be negative. So in summary, chest X-ray is not indicated for patients with chest pain who presented to the emergency department. Next. Looking for pneumoperitoneum when we are dealing with acute abdomen. When we receive patients in the resuscitations area with abdominal pain, usually we do X-ray upright or decubitus to look for pneumoperitoneum. Please, I want to remind my colleagues to do the chest X-ray portable, sitting as much as possible, even to a 90-degree, and allow 3 to 5 minutes for sitting in that position so that the air will accumulate, and then you shoot the film. If the patient is unable to sit, so you have no other option aside from flip them to the side and do the decubitus film. Sometimes the air under diaphragm is quite large, as you can see in this film, quite large and obvious, and can be really easily identified. But on the other hand, the pneumoperitoneum, as you can see in this image here, is really faint and small and may be missed by most of us. So pneumoperitoneum can be very difficult in the regular radiograph, chest or decubitus, and the best thing is to consider CT scan. When we want to send patients for CT scan, as you know, they should be hemodynamically stable and not in pain. Otherwise they will send the patient back to you to the emergency department. Look at this patient. The patient was unable to sit because he's an elderly and the feeding tube, etc. As you can see, the patient was flipped on the left side. The feeding tube is going down here, and the right side is up. Here is the liver somewhere, and air pneumoperitoneum is quite obvious in the right side, decubitus side. And this sign is called decubitus abdomen sign. CT scan is the best to look for pneumoperitoneum. If we do CT chest and abdomen, please choose the lung window and scroll down in the abdominal cuts and look for pneumoperitoneum. As you can see here, just anterior to the liver, we have accumulation here of a nice pneumoperitoneum indicating perforated viscus. Please do not delay surgical consultations if we have sick patient. Do not delay. So we have to speed up the management. As you can see, now we have point of care testing ultrasound. We scan the patient and we look for fluids inside, blood inside, etc. Many conditions, you know. If you have a surgical abdomen and the patient is quite sick, even if they don't have pneumoperitoneum, surgical consultation is very important, and sometimes patients will be taken for exploratory laparotomy even if they have a negative imaging based on the clinical aspect. Anyhow, pneumoperitoneum on a sitting film or a decubitus film is a good finding to encourage the surgeons to look for the site and of the perforation and decide the surgical management. Please remember that accumulation of air in a small site, in multiple sites in the abdomen, is really a point of interest to our colleague in radiology department. Radiologists are very interested to look for these small accumulations of air, right or left, but it's not of our interest, and we leave these more than 20 signs of pneumoperitoneum accumulations to our colleague in radiology. One phenomena is accumulation of air under the right hemidiaphragm in the subdiaphragmatic area. As you can see here in this image, if you look closely here, you can really identify the hostria of the colon. So actually, that is the colon interpositions under the right hemidiaphragm. This rare phenomena was described first by Demetrius Chilaiditi around 1900. Demetrius was a Swiss radiologist, and he described this phenomena in 3 or 4 cases. It's really actually rare, but very interesting, because that tight interposition of the colon may lead to abdominal pain and may perforate. So surgical consultation and CT abdomen is very important for these kinds of the patients. This position of the colon under the hemidiaphragm is called HDI of the colon, or hepatobiliary diaphragmatic interposition. Next, we have an elderly male or female patient had a fall trauma at home. They brought in to the emergency department, and we are suspecting hip fracture. We proceed to order pelvis and hip X-ray, and we look at the anterior posterior projection or the lateral projection, and we identify no fractures. Patient is unable to bear weight and stand and walk, so we are calling this phenomena query occult hip fracture. Query occult hip fracture in the presence of negative plane radiograph indicates CT scan of the hip or the pelvis, and then you proceed for CT scan and you identify no fracture again. You know, look at this patient. The first image of the patient shows a very clear chin-to line, acetabulum, neck of femur, greater trochanter, lesser trochanter, no fracture whatsoever. And here is the ischium, superior ramus and inferior ramus. On the lateral projection, almost the same, you know. And the patient was taken again for CT scan. The right side, as you can see here, no fracture. The right side, no fracture. So what do you do now? Do you discharge the patient? Do you give them a walker and try to help and mobilize? Analgesia, orthopedic consultations? What shall we do? We have a negative X-ray and the negative CT scan. And the answer is MRI. The answer is MRI. Please do not discharge this patient. So the patient was taken for MRI, and look at this significant intertrochanteric hip fracture. So MRI is better than CT scan in detecting proximal femur fracture. The debate between CT scan and MRI is very interesting. Actually, in one study by Harun Rahman, he found the results are really comparable between CT scan and MRI. Harun Rahman favors the CT scan. Other scientists like Hebrew and his colleagues in 2015, they favors the MRI. Actually, Hebrew reported 2 cases were missed by CT scan, and that had dropped the negative predictive value of CT scan to pick up proximal femur fracture to 95%. So in a bottom line, MRI is better for proximal femur fractures. As you can see here, the coronal image of the CT scan, as you can see, it shows no fracture whatsoever. On the other hand, T1 weighted image and stair image of the MRI shows clearly the intertrochanteric fracture. Patient presented to the emergency department with headache or seizure or weakness or numbness, taken for a CT scan. The radiologist calls back again asking to give IV contrast. That's really a very good idea. Giving IV contrast in patients with CT head is really very important, as it will delineate and highlight more of details of the lesions. Look at this patient. Came in, CT scan on the left side was really nothing, but when we give contrast, multiple lesions here, they're suggestive of metastasis. One patient here, for example, 52 years old female, she had long standing of headache and neck pain, and one day she had this tonic-clonic generalized seizure. Brought into the emergency department. The first scan done for her shows inner calcifications, little bit of hypodensity area around the calcifications, but the radiologist was really smart. He gave IV contrast, and look at this. Now the destruction around the calcification is very clear. MRI done for the patient, and it shows huge infiltrative tumor. Giving IV contrast means consent and family discussion. So we have to call the patients back again to the emergency department, explain to the family, convince them that the IV contrast is very safe in a patient with a normal kidney function and has no history of contrast allergy, and it will be excreted by the kidney. As you can see, we have many differential diagnoses. Many differential diagnoses are really highlighted much. The most important one of them is malignancy. 1/3 of brain tumor is glial primary parenchymal brain tumor, glial tumors. And as you can see, majority of the glial tumors are the astrocytoma, which is really further subdivided into high-grade, intermediate grade, and low-grade astrocytoma. And the high-grade astrocytoma is called GBM, glioblastoma multiforme, and these are very aggressive tumor, and they highlight with contrast in a beautiful fashion, giving a ring-enhancing lesion on CT scan. Even on MRI, if you do an MRI, the GBM highlight really more than the others, So diagnosing these lesions is quite important in the emergency department. Next, the elderly patient comes to the emergency department with chest pain and cough. Chest X-ray was done, did not show anything, was read by ER physicians. Radiology did not show much. Patient was discharged with antibiotic. Indeed, the radiology consultant called back again to bring the patient for further imaging, and he said that, guys, sorry, there is an apical opacity. We have to screen the patient and scan him again. Actually, indeed, this apical destruction is really very important. The lung apex and the lung base, these two sites are sometimes difficult to visualize, especially in a busy emergency department area. The apical malignancy was really studied by Professor Henry Pancoast. Professor Henry Pancoast was the first American professor in radiology. In 1911, he completed his work for the apical neoplasm, and actually this neoplasm was given his name. As you know, the tumor invading the brachial plexus, giving a lot of pain to the patients. The mortality was high for these patients, and nowadays with oncology, with chemotherapy, radiation, surgery, the survival, the 5-year survival for these patients improved to more than 30%. Look at this patient. The tumor is very aggressive, invading the nerves, giving to a lot of neuralgia pain. One of my patients actually needed ketamine IV infusion, so that the patient really his pain can be relieved. Okay. Next, foreign body. Very difficult question. which imaging is really good to detect foreign bodies. Foreign bodies can be glass or wood or metallic or etc. Sometimes we do X-ray for foreign bodies in the emergency department, hand and feet and skeletal, and we see nothing. Patient is still complaining of pain. It's quite difficult. And majority of the X-rays are negative. Actually, one radiologist from Salt Lake City, Christopher Ingraham, he's an interventional radiologist. He studied this phenomena and he came up with a very nice suggestion. Maybe his landmark paper was the best in detecting foreign body by different imaging modality. Look at this boy, for example, 11 years old boy. He was playing in the bush, fell down 3-meter height, and then unfortunately a branch of a tree impaling his left thigh and penetrating the obturator foramen and inside. The foreign body, the tree branch, was missed by the regular X-ray here, but it was really, when the CT scan was done, it shows clearly the foreign body inside. So regular X-ray is not good to detect foreign bodies. Ingraham said, let's study this again. So what did he do? He brought an animal model, an animal cadaver leg phantom model from an animal, and he inserted all of the foreign bodies encountered in the emergency department within the leg phantom. So he shows in plastics, wood, aluminum, gravel, glass, fish bone, etc. As you can see here in the middle, different wooden foreign bodies. In the middle we have some glasses, gravels as well, and fish bone here. And so he went ahead and he screened, he X-rayed the leg phantom using ultrasound, CT, MRI, etc. And he came up. Look at this regular X-ray. Majority of the foreign body here in the leg phantom are not really seen. Look at the wood. Look at the wood. It's really not visualized at all. Maybe 5 or 6 foreign bodies are obvious. The others are not appearing. Ultrasound is the same. If the foreign body is superficial, you may be lucky to see it on ultrasound, or you can see the track. But usually, if the foreign body is really deep, it's very difficult to see the ultrasound. CT scan is better. CT scan, you can really identify the foreign body or the effect or the track of the foreign body. MRI, not good modality whatsoever. MRI, please do not consider MRI to look for foreign bodies, because the chance that you will see anything of the MRI, even a glass appearance, is very low. So MRI is not good, is not really a good criteria. So look at this. MRI was compared to regular radiographs, CT scan, and ultrasound. MRI, not good option. Actually regular. So I will do regular X-ray and then to CT scan right away, and then consult the particular surgical specialty if in